I've been asked today to talk a little bit about what happens next. So you've got concerns for abuse. What do you do? What happens to these children? Kind of what's the workup? Primarily physical abuse, since this is trauma grand rounds. So now I gotta make sure this actually goes forward. There it is. So my objectives today are to discuss, there you go, when to become concerned for physical abuse, the workup of a patient, the role of CPS and law enforcement, and then some of the outcomes. So suspecting physical abuse, really be aware. This is primarily when we have a case where the history does not match the child's presentation. You have an infant that comes in and they said they rolled off the bed and they have like 8 broken bones. Something that doesn't make sense. A child who's not developmentally able to do what is reported. I think we had one where the child was like weeks old and supposedly had scooted across an adult bed to fall off. History that changes considerably, and this one I definitely take with a grain of salt. It's not as simple as, well, mom reported what dad told her and then dad came in and clarified. Or what we'll see sometimes is the propagation of the same incorrect history throughout the chart. You cut and paste and cut and paste and cut and paste, and turns out the first one was incorrectly gathered. It's really going to be that, oh, the child, nothing happened. And then, oh, well, I do remember that the child bumped the child's head on the door frame. Oh, you know what? Maybe that's when the kid fell down the stairs, and they keep getting this new history. That's really going to be your changing history. And then a significant delay in care. And again, taking that with a grain of salt, significant being frequently a child who's clearly unwell or clearly needs medical care. We'll have a lot of the kids with the infants who roll off, smack their head, get a skull fracture, look well. They may take a couple days until the swelling shows up and then they show up for care. That's really not a delay in care. It's a delay in necessary care that we're looking for. So I'm going to talk a few other injuries that are highly specific for abuse. I'm going to talk about fractures, 10-4 facies, and head trauma. So fracture specificity, this is a really nice table to look at. First of all, let me start off with any infant who has a fracture. Somebody should be questioning that because they're non-ambulatory, most of them. And it's very difficult for a child to break. We just had one where the mom was like, oh, I think she hit her arm on the side of the crib. Okay, that's not going to break a bone. So there needs to be a good history. Or the other one we get is nobody knows, but maybe somebody rolled over the child in bed. Again, not going to happen unless somebody knows. So the ones that we really worry about are these on the far left here. So your CMLs, common metaphyseal lesions, metaphyseal fractures. These are also chip or bucket handle fractures. They occur at the very end of long bones, usually as a result of a pulling or traction injury. Very specific for abuse. I've done a couple case reports, and that's really all we have of case reports of iatrogenic causes of these injuries. Pulling, twisting during clubfoot treatment, or IV placement, or a breech delivery where somebody pulled on the extremities. That's about all we see. Rib fractures are another one, very specific for abuse. They, outside of a car accident or some other high force injury. And then the other one, scapular, spinous process, sternal. These are low, less common injuries, but high force again. A car accident is one thing, ejected from a motor vehicle, whatever, but not from rolling off a changing table or routine care. Moderate specificity, again, depending on the history, depending on the child's age and development, multiple fractures. One incident usually causes one fracture. Again, forearm is one, both bones or the lower leg, but usually you'll get one, maybe with your higher force ones, 2. But when you start to talk about 3, 4, 5, 6 fractures, you really got to question the history. The other one is fractures of different ages. How is this kid breaking multiple times? And are they getting care with the first one? Epiphyseal separations, vertebral body fractures, digital fractures, and complex skull fractures all require more force. Something more is going on, and you really have to start asking questions about why. Less concerning, I had already mentioned your linear skull fractures. That is reasonable from a child who is able to roll, rolls off of a changing table, gets dropped by a slippery baby dropped on the floor. They can cause a linear skull fracture, no other injuries, maybe a little blood underneath, child's otherwise well. That is a reasonable history for an infant to get a fracture. We also have long bone shaft fractures, which bread and butter orthopedic surgery. All of our ambulatory kids can get these by running, jumping, playing, doing the crazy things that we like kids to do. Clavicular fractures are another one. They can be caused by birth. So the 2-3-week-old who presents with the bump on the collarbone, probably a birth injury. Or again, your ambulatory running around child who falls and lands on something. But none of those you want to see, none of these two you want to see in a normal infant with no history or with mild trauma. And finally, subperiosteal to new bone formation. This can be seen with a bone that's been traumatized and you get blood that seeps out between the bone and the periosteum. So it looks like a little shadow on x-ray. But it also can be physiologic in young infants, especially if it's symmetric. So here, I hope it projects better than it does on my screen. We've got a linear parietal skull fracture, which runs right through the parietal bone there. Again, can definitely be an accident with the right history. I mentioned rib fractures again. I'm going to talk about them because we do see these. We get the chest x-ray and we incidentally find a couple of them. You know, the child who comes in with the arm fracture, we get the skeletal survey, we find rib fractures. Very specific for abuse, rarely if ever the result of accidental trauma in a healthy infant or child. Not to say we don't have a horribly ill premature baby, which is a different story. Here's an example. You can see these nice callus formation here on these rib, so posterior rib fractures in this infant here. Definitely noticing that there's lots of other stuff in the ribs that are important, you know, heart, lungs, that sort of thing. And a brand new fracture, these are healing because they get the callus, a brand new fracture may be missed, which I'll talk about later, but this is one of the reasons why we get repeat skeletal surveys on our children where we've got a high suspicion for abuse. Another thing to remember is 10-4 facies P. This is a really nice mnemonic. It's a clinical decision rule developed out of Lurie Children's. Mary Clyde Pierce is a colleague of mine and a friend and has done some amazing work. She's actually an ED child abuse. And she has done a lot of research on where do we expect to see bruising in infants and where don't we. So in children less than 4, any bruising on the torso, ear, neck, and then the facies, the frenulum, angle of jaw, cheeks, eyelid, and subconjunctiva or sclera, either one. Those are areas which are highly concerning for abuse. They are not diagnostic. So there can be crazy stories that go with them, but that's worth asking the question, possibly doing a workup, really evaluating why does this child have this bruising, okay? Any infant younger than 4 months or 4 months and younger, any bruise anywhere, they should not have bruising. We have a lot of kids who come in, is it a bruise, is it not? A few things that you can do, bruises will not blanch. So a lot of our birthmarks, you know, the stork bite on the neck or the angel kisses on the forehead, those will all blanch. You will not get blanching on a child with a bruise. And then if you're not sure, still trying to figure it out, you can see them back in a couple weeks and the bruises will disappear. And then so that you end up with your pattern. The P up here is for pattern bruising. Any pattern bruising has got to be concerning. What does it look like? Is it a slap mark? Is it a grab? Is it a loop mark? And I think I've got some coming up here. Here's the ear. One of the things when you're evaluating a child with suspected abuse, don't forget to look at the ears. Girls with long hair, it covers the ears up, so don't forget to look there. And definitely check behind. Very specific for abuse. You know, usually caused by a direct blow or grab. Here's the neck. Pretty clearly, this is very concerning. It's also a patterned injury. Here's your facial bruising. So the meat of the cheek should not have bruising on it. This is a slap mark. So we have a patterned bruise and we have a cheek bruise. Here's your frenular injury. Unexplained mouth bleeding. Don't forget to look at the frenula. For trauma. This is caused when something hits the mouth or when something's shoved into the mouth. Here's your subconjunctival hemorrhage. We can see these, and people have seen these with excessive abdominal pressure, with some other things, usually not straining to poop. But it's worth asking the question, how did this happen? What what's going on with it and looking for other things. If I just have an isolated subconjunctival hemorrhage, I might still be figuring things out. But if I have that and I start looking and I find, oh, by the way, there's an ear bruise, or oh, by the way, there's a frenular tear, or look, there's this big torso bruise, that's going to really raise my level of concern. And here's your eyelid. Remember that our eyes are well protected in our bony orbits. They're recessed back. And if you do a face plant, you get your nose, your forehead, you get your bony orbit all around the eye. You don't get your isolated eyelids. So this right here, just looking at this kid, I could be really sure that somebody hurt this child. They're not going to do a face plant onto two objects and miss all of the other areas. Here's a great example of a pattern injury. This is a spank mark. And you can see here how there's bruising of the buttocks and then sparing of the gluteal crease. And this line right here, when the child closes her legs, will line up and meet. And it happens when the skin folds right along that edge. You get this distinct line. So seeing this is not I fell and landed on my butt. I showed you a handprint. I think I've got some loop marks here. This child here on the right has got loop marks. And then also this one, it's a little harder to see. My screen is glaring, but you've got loop marks along here. So this is all of what you'll see with a cord, a belt, something that loops over and then is flexible enough, as you can see here, to wrap around the body. And then bottom left here is another handprint. And interestingly, this person had a ring on, so it becomes, you can see here though how the blood is pushed back, on the outside of the fingers. So you get a negative impression of the hand when you have that. Okay, I will definitely take questions at the end because I don't have the ability to really get through the chat. But if you do have questions, start putting them in and I will go through them all. Okay, there we go. Abusive head trauma. We see our share of these. I would say maybe 6 to 12 a year. I think we average 1 or 2 deaths a year from this. It's a horrible condition. This is the medical term for shaken baby syndrome. And this is really what we should be using when we communicate with investigators and when we communicate with each other. A couple nice definitions, but really recognizing that it's a brain injury caused by the application of force by an adult or by a caregiver, depending on how you want to frame it. What do you find with abusive head trauma? So you got a child who comes in, usually they have some sort of clear brain injury, but you may not. We'll find intracranial hemorrhage. So subdural is the most common finding we have with abusive head trauma. You may also have subarachnoid or cerebral contusion. I mentioned brain injury. We'll see retinal hemorrhages in about 80% of these, and about half of them have something else. So I mentioned the bruising and the fractures. You might have spinal cord injuries, something else associated with that. Just a refresher on the anatomy. This is the brain here in tan and a contusion to the brain itself. Recognizing that the subdural space, which is shown here, is actually a potential space. It does not exist unless something fills it. Different from the subarachnoid space, which is where our cerebral spinal fluid is. So there is a membrane that separates the two, although we can see tearing of the membrane and mixing of CSF with subdural. I mentioned, a majority of children with abusive head trauma generally thought to be the result of shearing of the bridging veins. There is also the vice versa. So most kids with abusive head trauma have a subdural, but a majority of your children who present, especially infants, with a subdural hematoma have been injured as a result of abusive head trauma. Again, if they have a car accident, if they have some other clear, well-recognized trauma, that's a different story. But many of the cases I have, one of the first questions I get is, well, maybe it just spontaneously occurred. Well, subdurals are usually caused by some sort of trauma, so you have to find a reason for them to have had that trauma. Abusive head trauma, the classic presentation is going to be the bleeding located over both convexities, so both halves of the brain, in between both halves, and then frequently up underneath in the tentorial. So very extensive, maybe not very thick, but very extensive. By sometimes a kid who has a single impact might have a little focal subdural or subarachnoid right there where they hit. Here's an example here. You can see this white, which is much more intense than the brain. This is going to be the subdural. And if you look on the other side, you actually have fluid in the subdural space on the other side too. So this is pretty classic for what I will see in cases of abusive head trauma, this extensive of the bleeding. Here's an example on the CT scan of what we call the tentorial. It sits right between the cerebellum and the cerebrum, and you usually catch it. It looks a little bit, brighter in this whole area. And then as you slice through, you'll find this line tends to move as you're catching the different areas. And then remember that abusive head trauma, the subdurals are not the problem. Although the first one I showed you has a pretty large space occupying, but the problem is actually the brain injury. So the same forces that cause the subdural also injure the brain. And that's really what kills these kids. That's why in many of the kids that come in that they try to do a decompressive craniotomy or craniectomy and they can't. So no, they don't succeed in helping the child survive because the brain is already injured. There's only so much we can do in some of these cases. So the reason why the brain doesn't do well is one, obviously the shaking, the forces injure the brain. Then what happens, one of the first things that happens to these kids is they stop breathing. Clearly not good for an injured brain, clearly not good for any brain, right? So you get hypoxia from that. And then you add on top of that, the injured tissue releases all of their modifiers and all of the stuff from being injured, and you get ischemia. So you get vasoconstriction and inappropriate vasodilation and other sorts of bizarre things that can happen within the brain, which further compounds the injury. And then finally, unfortunately, many of the cases of abusive head trauma I see do have a delay of care. The report is they stop breathing, so somebody puts them in the bathtub. Or they try to shake them to revive them, or they pat them on the back, and then they do all sorts of crazy things. They call their mom, they call the baby's mom, and it's a delay of time before they're calling 911, which makes zero sense. So that delay of care that we have compounds the injury even more. Retinal hemorrhages, again, the same forces, shaking, rotational forces, shake the brain, cause the subdurals, also cause the retinal hemorrhaging. And if you guys remember Dr. Saw, who was here a few years ago, he did a lot of work on the forces involved. And the leading theory, which is probably true, is that these are caused by traction of the vitreous on the retina. So pulling apart the vitreous from the retina, almost a great analogy is like pulling off a scab. And what you get is you can see here all of this oozing of blood along the entire back of the retina. This is what we look at with an ophthalmoscope. The left is normal, the right is clearly very abnormal. And here's another example too. You've got lots of areas. You've got bleeding here, large blobs of blood sitting in front of the retina. These are within the retina, intraretinal hemorrhages. And then you can see some that even the vessels go on top of. And so that's in multiple layers of the retina that we see this bleeding. And that pattern is very, very specific for abusive head trauma. You can see a couple of posterior pole retinal hemorrhages in other conditions, a bad head trauma related like a motor vehicle collision. You can see it with some bleeding diastases. You can see it with a couple other conditions. Birth, about 40% of kids are born with a couple of retinal hemorrhages. But this pattern that you see here with multiple layers, extensive, sometimes all the way out to the ora serrata, those are really going to be only seen in abusive head trauma. And then remembering that brain injury is bad. We all know that. You can have minimal consequences in our more mild cases to severe. As I mentioned before, we usually have a couple fatalities a year. We also have our share of kids who survive, but don't really survive well, and they end up at Madonna, and they end up with some pretty bad brain injuries. As I mentioned, it's usually the initial injury is going to help determine how severe the outcome is. But there are some great studies that show that even if they leave our hospital looking well, a majority of those children have trouble when they get 5, 6, 7 years of age with behavioral issues or learning disabilities. So certainly concerns that we have injury that isn't quite apparent initially. And here's a great example of the consequences. So this scan in this child, you can see very, very large ventricles. I can tell you this child's head circumference is incredibly small. So this is a hydrocephalus ex vacuo, or just it's the cystic changes as the brain, the dead brain resorbs. It fills up with a cerebral spinal fluid. Our skulls grow based on the brain pushing on them as the brain grows. And so when in a child like this, when the brain stops growing, we actually will see microcephaly. I've had quite a few kids show back up for follow-up, and they start to have overlap of their sutures because of the shrinking of the brain and then the skull adjusting to that. Just a real quick brief thing about abdominal injuries. This is one, they're rare, but please don't miss these. They have a high fatality rate. When children suffer from abusive abdominal injuries, it's usually a smaller surface area like a fist or a heel, and we'll see higher injuries of like the hollow organs. So we'll see duodenal hematomas or even lacerations. So we may see a host of injuries that might be a little bit different from some of our car accident injuries. So keep this in mind. This is why I always recommend getting AST, ALTs in these kids. If they're greater than 80, definitely consider further imaging just to make sure we're not missing anything. Although incidentally, we've seen a whole bunch of kids with transaminitis, probably related to viral illnesses, but it's certainly something to look at. And this again is another reason why we do our secondary and tertiary surveys, to make sure that we don't miss. This child comes in clearly not breathing, has a head injury. Let's not also miss the abdominal injury. So what is your role? What is the role of the medical team in cases of abuse and neglect? Suspecting it is definitely up there. Abuse in itself, if you include neglect and if you include sexual abuse with physical abuse, is more common and more prevalent than about any other medical condition short of the common cold. It's more prevalent than cancer. It's more prevalent than type 1 diabetes. It's there. And so I always tell my colleagues, if you don't see abuse, you're missing it. And then recognize that our burden of proof for reporting is concern. Our burden, where should we be to do a workup? I'm concerned. We don't have to prove abuse to do a workup, and we don't have to prove abuse to make a report. So just remember those couple of things. It helps alleviate some of the concern that a lot of people report to me. Another thing is really be careful of bias. I will tell you, one of my trigger words is when someone calls me and says, but the family's really nice. So what? That's the nice family to me tells me that whoever's telling me they're nice has bias, and they're identifying with this family because they're nice. They may be appropriate, and that's okay to say, or they may appear like they care for their child. And even better than that is to say they're picking their child up and they're holding them and they're cuddling them and they're comforting them. So concrete facts about what the family's doing. But there is no one type of family that's abusive. And this is also where risk factors come in. There are many different descriptors that are more common in abuse. For example, people who are families that have poverty, we see abuse more often in that. And that's an example of a quote unquote risk factor, which is wonderful for prevention. This will help us target families that might be at higher risk, but it should not be used in a diagnosis. We should not say, well, because this family is rich and white and from West Omaha, they can't have abused their child. So be careful when if you start to hear yourself saying those things, take a step back and say, let me just look at the facts. I have a 4-month-old who presents with a humerus fracture and there's no history. I don't care how nice the family is. That makes no sense to me. And this is also where we have our pathways. Please don't forget we have them. We have pathways upon pathways. So we have for the ED, for the clinic, for the inpatient team, we have them for sexual abuse, we have them for physical abuse. Please open them up. Please read them. Please let me know if you find errors. But these are helpful, and this is some tools that we can use to help mitigate bias. And I know there's a group that's working on trying to do some EHR triggers for abuse. So keep an eye out for that exact same reason. Let's help mitigate our bias and really correctly catch these kids. So the workup for abuse, the child comes in, you've got concern for abuse, what do you do? Well, forget that initially. The medical care takes precedent. A child comes in and is gasping for air and is in respiratory failure, I could care less about whether they need a skeletal survey. So make sure you get the medical care first. The other way we see it is when we're talking about doing eye exams, we have to dilate for them. We definitely need to make sure that that isn't a thing that we need for exam to look for increased intracranial pressure. So if we're worried about somebody blowing a pupil and we've dilated the eye, it can be a problem. The purpose of the workup is, one, to look for other reasons for the child's presentation. Was this an accident? Does it make sense? Does this child have a medical condition? You know, is there some other reason for this child's presentation? And then also to look for other injuries. I think the skeletal survey is the best example of that. We're looking for broken bones that might be indicative of abuse. The laboratory workup, again, all in the pathway, but just briefly, bleeding disorders, if it's not clearly abusive or clearly accidental, you probably need to rule out a bleeding disorder and look for it. I mean, we had a really great example many, many years ago. I had a 2-year-old who came in bruised head to toe. The aunt said the child was abused by the mom's boyfriend. Mom and the aunt got into a big old fight. I mean, it was a big old mess. And we were worried about abuse. Kid had a lot of bruising. He also had a platelet count of about 3. So he had ITP. I couldn't say any of his injuries weren't due to just, you know, routine movement and care in a child, you know, with a platelet count of that. But we still called CPS because there was a lot of other stuff involved. Also things, so PT, PTT, CBC, think about factor 8 and 9, which mild cases, especially in young infants, can have normal PT, PTT, von Willebrand. Abdominal, look for AST, ALT, pancreatic enzymes, urinalysis. And then for bone, if you've got concerns for bony fragility, calcium, phosphorus, alk-phos, and 25-hydroxyvitamin D. And that's going to get most of what you need for that. Skeletal survey, you're going to look in doing that in children 2 years of age and under. So 24 months, I should say, and under. Really, 2 to 5 maybe, especially if you've got one of the more severe cases, or if you have a child who's nonverbal. Really no indication to do a skeletal survey over the age of 5. And then I mentioned before, a 2-week follow-up. So we will see them back in clinic and we repeat the skeletal survey. We actually have, the literature supports us leaving out a few different images, heads, pelvis, spine, and we will then see if we missed an occult fracture or if there are new injuries in the meantime. Head imaging. Obviously, if the child is altered, they're going to buy themselves a trip to the scanner. That's a pretty straightforward one. But if you've got a normal appearing child, and they're under about 6 to 12 months, and you have clear abuse concerns, I would recommend getting a scan. I put all the different kinds of scans that we do here. The most common one we do in an acute ED presentation is going to be a CT scan. It's quick. It's easy, but it does involve radiation. An MRI, it takes a lot longer, frequently requires sedation, but on the other hand, it's really nice 48 to 72 hours into an abusive head trauma case to get an MRI, because then we can start to see evolution of the brain injury. When you're doing an MRI for abusive head trauma, I also would like to see a complete spine without contrast. We're finding more and more of these cases that have injury to the ligamentous muscles, the ligaments, to the spinous muscles, to the brain, the spinal cord itself. We'll see epidurals or subdurals within the spinal cord, within the spinal canal. So a lot of interesting findings that really support the diagnosis of abuse, and in some cases have actually needed monitoring or treatment. A rapid MR is a really nice study that we can do without sedation, but is only really useful in certain circumstances, like an acute change in mental status for a hospitalized patient, or I think there's a shunt series version. I mean, so there's specific reasons, but it's not very specific. It's kind of blurry, so it doesn't work great if you're trying to make a diagnosis. And then an eye exam. I see a lot of these. I'm thinking abusive head trauma and someone orders an eye exam. That's not an indication. The only time that an eye exam is indicated is if you clearly have concern for abusive head trauma. So abnormal head imaging, so subdural, a cerebral contusion, something like that, or an altered mental status. But if you've got a normal appearing infant with a fracture and a normal head scan, they do not need an eye exam. Admission to the hospital, usually it's a clinical reason. Again, the child abuse workup takes the back seat to the actual child's medical needs. Sometimes we will do a social admission in cases when there's not a safe discharge. That definitely will involve discussion with the team that's going to be doing the admitting, with social work, probably with my team. Where are we? Can we push them to find a safe discharge for this child? Sometimes at 2 o'clock in the morning, it's a little difficult. So that's a discussion that may happen. Okay, so you've had the concern for abuse, you do the workup. What else do you have to do? You have to report it. And so this is our Nebraska statute. So we live in Nebraska, we have to follow this statute. When any physician, medical institution, or other person, which is an interesting one, which means every adult is considered a mandatory reporter in Nebraska. But I will tell you, most adults are not held to that standard. Those of us who do this professionally are. So I have seen cases where egregious lack of reporting has led to a misdemeanor charge and or a civil lawsuit. So it is something to think about. The other thing is we don't have to prove it to report it. It's reasonable costs, which is really nice because many of these times I'm still doing the workup. We're still ruling a couple things out. But if you've got reasonable cause, if you're like, oh my God, I'm really worried, it's near the top of the differential, you've got those alarm bells going off, that should be enough to make a report. And then the other thing that he or she shall report or cause a report to be made. So luckily in Nebraska, we can delegate some of that responsibility or delegate some of that to somebody else, but we maintain the responsibility for it. So if you're in the emergency department, you can actually call social work and they will help you and they will make the report for you. Remembering though, that you need to ensure that that communication happens, that social worker who does not have a medical degree actually understands. Somebody not muted?
Also put a camera on a tripod, just like right around there. Mm-hmm. Is your storyboard going to be kind of here-ish?
Yeah.
Okay, thank you. So remembering that you can delegate to somebody to make that report, but you got to ensure it gets made correctly. And so every one of us has a responsibility to make a report or ensure that it has been made. And that's, again, where our team can help out like that. But a great example is we see kids who are seen at an outside institution or an outside ED, urgent care or something like that. And they're like, well, I'm going to send it to Children's and they'll make the report. That's not good enough. That first institution still needs to make that report even before, because then we run into trouble when the child doesn't make it to our ED or something like that happens. So if there's a chain involved, make sure that the report has been made or you are responsible. Okay. All right. Communication with investigators. These are so much fun, right? When the police officer shows up to the ED with their badge and their gun and they look like they're about 12. A few things to remember when we're talking with them. We can give them medical information. If they're doing an investigation, that trumps HIPAA. And I will tell you, if they're showing up, our social workers are also getting a release of it from the investigators to communicate with them. So that would be fine. Tell them what's going on. Talk to them about the child, your concerns. Again, speak English, not medical. This is a subdural hematoma, which is bleeding between the brain and the skull. So do what you can to make sure they understand what you're talking about. Definitely advocate for the patient and family. And be clear, there are cases where they come in and you're like, somebody else reported it and not concerned. You can tell them that and tell them why. Or on the other hand, we've also seen issues where we have really a lot of concern. A child comes in with a broken arm, is 2 months old, and there's no history. And some communication happens. The investigators, sometimes they make up their own story. And they're like, oh, I think we're still safe to go home. You know, they seem like a great family. If you're still worried, please ask why. Ask for help. You can call us. But if you think it's not safe for a child to come home, to leave or to go back with their family, even if law enforcement is saying so, please ask why and advocate for them. Be clear about what you do and don't know. There are many times when I'll get, you know, we're taught to look for zebras, right? What is the weirdest thing that could have happened? Well, maybe that's the one because we don't want to miss that. But in reality, I've never seen this as a result of, you know, an accident. So it's got to be abuse. I mean, that's really when you're thinking about truly. And that's what's nice with our ED staff, our primary physicians. You know what normal kids are like. And if you can say that I've never seen this from an accident, it's huge in some of these cases. Again, don't forget to ask for help. If you're within our institution, we are always available. We've got a provider on call 24/7. Don't forget to call us. And then documentation, very important. My team reviews all cases of reports that come through the hospital. And unfortunately, we find our share of cases where it's like the investigators say one thing and the medical record says something else, and I don't know what happened. So make sure that you guys document the best you can and with what happens as it comes through. Okay. What's next? What happens after the report gets made? So usually law enforcement and CPS are who you report to, especially with physical abuse. Law enforcement investigates in the jurisdiction where the crime occurred. So they could have actually been at the mall, and whatever the law enforcement is at the mall are the ones that are going to respond. CPS is where the family lives, and that could be Lincoln. So you may have different jurisdictions. If the child is injured in Omaha and they live in Lincoln, we're going to have two different sets of investigators. A lot of times it occurs very close in proximity. So what happens to them? The investigators come out. Well, there might be nothing. They may come out and decide, you know, there's really not enough. Sometimes we have, you know, like for our sexual abuse cases, it's a child-on-child case, and law enforcement's like, yeah, I'm not going to do much. You know, maybe we can offer some resources. Or, you know, so they may decide that there's not enough. They may put a safety plan into place. So this is a case where we think it occurred in the home, so grandma moves in and has to provide all the care, and mom and dad have to be supervised all the time. Or they have one parent, the parent who's alone with the child when this happened moves out, and the other parent is caring for the child. There may be a removal where the child is removed from the parent's care and placed into state custody. And like I said before, it's okay to ask why if you don't understand why the safety plan is happening. And there may be crazy things. We had one case not too long ago where we had a child who came in with a couple of injuries. Mom admitted to one and dad admitted to the other. It was kind of bizarre. So both parents had to be removed. So it's okay to ask kind of, I didn't understand this. How come both parents, you know, that sort of stuff. The removal usually happens just by law enforcement. And in Nebraska, they are the only ones who can walk up to you and say, your child's not safe, I'm taking your child. From the other standpoint, medical providers and caseworkers, so CPS workers, can ask for a child to be removed. And I think a lot of you have heard the term, I'm going to write an affidavit. Okay, an affidavit is just a sworn statement. It can say anything, and it can still be called an affidavit. What we can do is we can write an affidavit requesting removal. And then that has to go through the county attorney, who can decline, and through the judge, who can then also refuse to sign it. So it's not a guarantee. And I'm almost only doing an affidavit for removal in conjunction with a caseworker who knows what's going on, and or law enforcement. So just so you're aware of how that process works. Unfortunately, our current county judges in Douglas are asking more and more for medical witnesses and medical affidavits in our cases that have any medical. So the child who came in with a broken arm, clearly abuse, they're starting to ask for the medical side of it. Just so you guys know, we may be asked for more of that. I'm trying to work with our hospital legal to reduce our burden for that. So when a child's removed, they're placed into the care and custody of the state of Nebraska. The caseworker is essentially the legal guardian for consents. So if you need consent for surgery or something like that, social work will help you get a hold of the caseworker to do that. They will also determine visitation. So they can sometimes say the family can be at bedside and sometimes not. One thing to remember is many caseworkers think that if the child's in the hospital, they're safe and the parents can have free access. Unfortunately, we routinely have to remind them that we can't guarantee a child's safety. Our staff is not in the room 24/7. They have other patients to care for and cannot be providing that supervision. After removal, they'll assign a foster parent. A foster parent may be a kinship parent or traditional foster care. Kinship is usually a family or somebody who's known to the child. So it might be a teacher, it might be a neighbor, it might be their best friend's parents. If they are, and if the child has significant medical needs, remember that the family will need training and education on the child's care. Our children with a G button or, with significant medical needs. Remember, though, this is not termination of rights. This is removal for care and custody, but the parent still does have rights. And many times the caseworkers will look to the parents for medical consent. Parents maintain educational rights. And the whole purpose of the removal is to eventually get the child back with the family in a safe way. And so that's the first goal in juvenile court. So kids that are removed from their parents or CPS investigations go through juvenile court. There's only 3 counties that have a juvenile court, which are Douglas, Sarpy, and Lancaster. So Omaha, surrounding Omaha, and then Lincoln. The first goal, as I said, is to reunify the child with the parents. It's based on CPS, so it's child-centered. It's not based on a criminal. It's not trying to attack or accuse a parent. It's trying to find out how the child got injured and fix that problem. And these are some of the hearings that can happen. And that's where a termination may occur. It's not a very common thing, but it does occur in some significant cases. The other side is criminal court. That's this law enforcement. So when law enforcement comes out, child's got an injury, they try to figure out who did it. And they will do the criminal charges that result in prosecution. And it's beyond a reasonable doubt in those cases. Just trying to make sure I got time for questions. Just remember that some of these cases where law enforcement comes out and we're all clear that this child's been abused, there may not be a prosecution if they can't figure out who did it, which can be very frustrating in some of our cases. So testifying, it's pretty rare for those outside of my team. It occasionally does happen. I think the more common groups that tend to get called to testify are radiology and ophthalmology. Usually in our abusive head trauma cases, but just to remember that sometimes you may be asked to. I think a more recent one, we had everybody from surgery to ortho to you name it get called. Luckily, didn't have to go to court because everyone did a wonderful job in their deposition. You do need to be prepared to testify. So I am forever grateful for our hospital counsel. Amy Bones has done a wonderful job making sure that we have the support we need. She will actually arrange for an outside counsel to go with us to court to help prep us for court. If, again, in the rare case you do have to go, you do have an amazing amount of support, and it's way more than most of my colleagues have. So in conclusion, in cases of abuse and neglect, please work to include the family in discussions and appointments if you can. Remembering that many of these people who have hurt their children are not mean and evil, horrible people. They've lost it. They're frustrated. So do the best you can to be working with them. Don't forget to document. If you have a case, take the extra 5 minutes to make sure that the documentation is correct. That will save you. That actually has a higher likelihood of preventing you from going to court than not documenting. And that is my conclusion. Here's a few references that I had mentioned. But I would like to open it up for questions. I think there's a couple. Okay. It looks like we got an answer here. Someone asked about the pathways and where they can be found. Awesome. Thank you guys for doing that. Yeah, and I had mentioned someone was asking about elevated AST, ALT in the absence of abdominal injury. My guess is we've had a lot of these viral illnesses that cause a transient transaminitis. And I think it just happens at the same time. Many of our kids, all of our kids are getting those viral illnesses back and forth and, monthly practically. And it wouldn't surprise me if that's what's causing some of that. CPS, when do you call CPS and report? So the age of an adult is 19 in Nebraska. So anybody 18 years and under is considered a child. If you have a 19-year-old or above that you're concerned that's disabled, you can actually call APS, which is Adult Protective Services. It's a little bit different, but we have had our share of cases, especially our children who are patients who have then graduated to adulthood but still come back and see us because of their chronic medical needs.